right, good afternoon, everyone. Thank you for joining us for this lunchtime conversation called Delivering News and Care During COVID-19 and the Uprising for Racial Justice, a conversation from the front lines. I'm Allison Ferguson, the Chief Operating Officer at the Thomas Scattergood Behavioral Health Foundation here in Philadelphia. We are co-hosting today with the Wellbeing Trust, and we have invited you all to hear from two amazing people that are doing extraordinary work on the front lines of our dual national crises. Many of you may know Kathleen Noonan, the CEO of the Camden Coalition. She's been leading some very progressive healthcare work, some of the most progressive healthcare work in the country, I would say. And we are very lucky and fortunate to have her in our own backyard of Camden, New Jersey. Kathleen is joined by one of our partners, Dan Gorenstein. He's the executive producer of Tradeoffs. It's a national nonprofit podcast that's we're also fortunate enough to have based here in Philadelphia. The Tradeoffs work really gets to some of the most complex health issues that our country is facing, everything from COVID to understanding the social determinants of health, the impacts on mental health, substance use, and much, much more. And you may recognize Dan's voice once he gets started from his days from NPR's Marketplace Report. We are really, really grateful to have people join us, and we want you to hear today from these two really in kind of their natural conversation about their work and how the work they've done together has been a terrific example of what happens when journalists and podcasts have empathy, they use data and bring rigor to their work. Kathleen's really going to share how the working with Tradeoffs has played a critical role in her organization and their growth and trajectory this far. A few housekeeping items. During Kathleen and Dan's discussion, you can send questions into the chat function at the bottom of your screen. Ben Miller, our partner from the Wellbeing Trust, he's gonna moderate those questions towards the end of the webinar. As Ben mentioned before, the webinar is being recorded. We'll be sending a follow-up email with any requested materials and a link to the recording. And finally, I just want to say thank you so much to the Wellbeing Trust team, the Tradeoffs team for really getting us organized, supporting all the logistics for today, and for Kathleen taking time out of her busy day to speak with us all. So I think that's it. With no further ado, I'm going to hand it over to Dan and Kathleen, and they're just gonna jump in and get us started in the conversation.
Great, Allie, thank you very much for that really nice, warm introduction, and thanks to everybody for joining the call. Kathleen, thanks so much for being willing to take some time to have this conversation with me. So we're just gonna dive in. I think part of this for the audience is to really try and to give people a sense of what your organization, Kathleen, has learned over the last 5 months during COVID. This has probably been a really intense time for you all. What are one or two key things that you really feel like you know now that you didn't know before the pandemic?
I think that one or two things that maybe I knew, but the pandemic has put such an exclamation point on, is I think first that in many places across the country, and certainly in Camden, we have done a really good job at creating a coalition of diverse practitioners, social services, health services, government, and consumers. We have consumers who are graduates of our programs. And I think what the pandemic has created an exclamation point for me is that we can get a lot of ideas from the community into in the room where it happens. But it's very hard right now, given how healthcare is structured, for those ideas to really be acted upon. And so with all of the talk right now about consumer voice and the importance of people with lived experience, it has to be coupled with a change in how we make decisions.
Sorry.
Yeah. So that's the first thing I just want to say. And then the second thing is we are not set up to move quickly. Our healthcare systems really act in parallel to our social service systems, which act in parallel to our public health systems. And we have to do a better job of figuring out the collaboration part.
When you talk about getting into the room, and then you couple that with this business about collaborating, can you just expand on that a little bit to give the audience a bit of a bird's eye view of what you actually are experiencing when you say things like that?
Yeah, I mean, an example would be, really asking community members where the best places would be for COVID test sites. Realizing that Camden City didn't have a test site before the suburbs, despite it's sort of just extreme risk factors. And this is not, I'm not telling you an unusual story. This story can be repeated across the country. So I just want to say, I'm not calling Camden out. But by the time we were able to inform people where we thought the test sites would be, the decisions were 10 steps ahead of us already. And so, we did not, think the original test site was a great site. And it ended up, the test site ended up happening there, and it was taken down. 50% of the people that went to that test site were from the suburbs. It was based on car traffic and not people who could walk in. There was no public transportation to get there. I could go on and on. And the thing for me is that these are good people, good colleagues, right? Like people who ask our opinion, but there's something about the decision-making process that by the time you get the consumer input to the people who've asked the question, that like the horse is already out of the barn. And so we have to do a better job of synchronizing. If we really want community input, we really have to do a better job of synchronizing and some other level of inclusivity in our decision-making.
And so when you think about doing a better job of synchronizing, being sort of at the front lines, you are consulted, you are kind of included people now, whereas years ago you wouldn't have even been included, right?
Exactly.
You wouldn't have even been invited.
Exactly.
You are now invited.
Yeah, exactly.
But,
right.
but your voice is not one of the first consulted, and sort of, as you talk about sort of the horse being out of the barn, how do you make that change now? And so when you think about yourself as an organization, and as you have grappled with the challenges of COVID,
yeah,
how have you tried to position yourself so that mistakes that have been made historically aren't compounded?
Yeah, well, I have to give my board and the hospitals, the anchor hospitals that we work with, a lot of credit, because we had our retreat the other day, and the first question that we grappled with was what did we do well as a region, and what would we do differently the next time? And so I could say candidly, we didn't think that site was going to work, and how do we change that next time so that we don't waste time? And so, and very candidly, one of the board members said, we haven't had the conversation yet about what went right and what didn't. And it's partly because we still feel like we're in the middle of the crisis, right? So it's almost like we are letting our guard down if we say it's time to sort of reflect, because we're still in action mode. But I think you do have to have some type of coalition like ours, and it doesn't have to be run by a nonprofit. It could be a coalition run by a hospital or run by community services organizations, but where people actually call the question, what did we do right and what didn't we do right? So, and our community, the chairs of our community advisory committee are on our board, so they were able to be in those conversations. And so I think that's really important.
And so one of the other, just in full transparency for the other folks who are on the call right now, Kathleen and I had we talked in advance of today's session, so we could sort of hammer out what exactly we're going to talk about and what this Q&A was going to cover. And one of the things that we talked about is an episode that Tradeoffs worked on about a man named Antonio. And Antonio's experience really, I think, Kathleen, is an illustration of one of the things that went wrong in Camden in the response to COVID. And I actually have a little bit of tape queued up from the story that I'd like to play.
Yeah.
But before I do that, would you mind just sort of helping people understand what Antonio's situation is? And before you do that, the reason I'm asking this in the first place, and we're going to talk about Antonio, is because it's one thing for you to make your phone calls or do outreach to community leaders. It's another thing if and when these community leaders are hearing a podcast or picking up the newspaper or in some other way hearing about the people that you represent, and to have multiple channels of information coming into these decision makers actually is in fact effective. And so that's really what we're talking about here.
Yes. Yeah, absolutely. So Mr. Moore, Antonio, is he is part of our Housing First program, which is a program that comes out of our care management program. So we do care management in Camden for people who have, usually some addiction, mental health issues, and other chronic physical health issues. And we find that if they are housing unstable, and many of them are, the best thing we can do for them is house them, and not house them in temporary housing, but in permanent housing. So they feel like all of us do, like, okay, my housing is settled. And so, and then when he's in that housing program, we have a community health worker who's able to check in on him and make sure that things are going well, and that life is getting better, and that his health is doing okay. And so Mr. Moore in particular, and I'm glad we're going to listen to the clip, I think points to one of the bigger problems that we have encountered in this pandemic, which is this constant calling out that the community needs to be educated. And as you'll hear from Mr. Moore, he knows exactly what's going on. It's not education he needs. It's many, many other things, but he knows exactly what's going on.
Yeah, and let me, I'm going to try to share a screen, which I hopefully don't screw up here, everybody. Let me get to it. And here's a little bit of the clip. And to set the scene, and Antonio here, let me see, sorry. Can people see that?
Yeah.
Great. So Antonio, Antonio has been, things have been good, right? He's
still great now. Yeah.
But in his life, we talked about somebody who wrestled with addiction issues since 1987.
Yeah.
And in and out of jail, in and out of prison, in and out of being homeless. And really, for the first time in his life, thanks to this housing program, he had found stability, and he was using his voice, and he was a part of a group of men who were getting together, meeting every week to talk about issues, to confront challenges. But he had found sobriety and found in himself his voice. And then comes February, and he gets a phone call from the doctor he'd been getting his monthly, what kind of shot is it, Kathleen?
He gets buprenorphine, which is a medication-assisted treatment for an opioid addiction.
And he'd been getting that shot once a month since August of 2019. And then in February, he gets a call from the doctor saying, don't forget, you need to come in March. And that meant Antonio would have to get on a bus, go about 7-8 miles, a packed bus, shoulder to shoulder, in COVID. And because of his chronic health conditions, he actually is incredibly vulnerable to catching COVID, to dying.
Mm-hmm.
And so he had to make a choice.
Mm-hmm.
Should he get on the bus? Should he not get on the bus? And if he didn't get on the bus, and if he didn't get this shot and he got the cravings back, would that mean he'd end up using heroin again? So this was this harrowing decision and choice Antonio had to make. And we're gonna pick up and we're gonna hear from Antonio about what exactly was going on in his mind as he was contemplating whether or not to get on the bus. The clip runs about a minute long here, guys. Antonio was as sober and stable as he had been in decades, but the fear of getting the coronavirus had him thinking of turning back to his old comfort, heroin. It was an ugly choice, and it didn't sit right. Friday night, the pacing started. Antonio turning over his choices, his anxiety ratcheting up.
It got worse and worse and worse. The anxiety got really bad. I couldn't sit down for 5 seconds without my body just reacting. And I would just walk around the apartment back and forth and talking to myself. And then after a while, it got so bad that the anxiety started making me throw up. I was in bad shape.
He got so twisted in his thoughts and fears, Antonio barely slept. By Sunday, he needed some help.
At first, I was embarrassed and felt like I was weak, but after about 2 days, I started reaching out to people because I was like, I got to tell somebody what I'm going through.
So there you go. And I just want a quick shout out again to Antonio. This stretch of time that our nation has been through has been a challenge for all of us in many ways. And there have been moments when I have thought back to the strength, the courage of Antonio and how he stared this down. And he ultimately, we'd love for people to go listen to the episode, but he got on the bus.
Yeah.
And I think bringing it back to the point that you're trying to make, the question is, how do you support people like this in real time? And even though you're being invited into the room, which is an acknowledgement of the lives of people like Antonio really matter to the people who've invited you into the room, there's a distance between that and making sure that people like Antonio are being taken care of. And so what do you see, Kathleen? What is that role that you think media can play, that a podcast like Tradeoffs, but others can play in helping you achieve your goals?
Well, I think that, first of all, I mean, the 10-minute clip that it ended up being about Antonio Moore is so powerful for us to share with people, because we can say, this is not about more leaflets. It's not about more education. The people in places like Camden and other places where we work in the region know exactly what's going on. Yeah, there might be some misinformation in the same way that there is misinformation in a lot of communities, but they know what's going on, but the choices that they have to make are different. The choices they have to make to be able to get to the doctors, to be able to get groceries, to be able to go to their jobs, are different than the choices in a lot of communities. And so mobile transport and mobile testing and including supermarket workers as essential workers, and going to corner stores and making sure those people are tested becomes really, really important. And so what Antonio gives rise to is this idea of this, you conjure up the idea of the addict who's been an addict and in and out of prison, and you realize that this is a person who is really trying to live their life in a different way. And I hope that conveys to the policymakers we're talking to some different level of stakes, and some hopefully helps us make the point that this isn't just an undereducated, community, right? They are presented with different choices, and we have to respond to those different choices with different resources.
It can be difficult, though, in the natural give and take of a meeting, of a conversation, even, to try to bring that kind of humanity, that granular sense of humanity, right? Yeah. Because you guys are talking logistics, and we're talking about funding, and we're talking about more partnerships and all of that. That's what is happening typically in meetings, or when white papers are going back and forth.
Yeah.
It's not the intimate portrait of a person. And so do you think, as somebody who's been in and around the issues of social determinants of health and the marginalized people in Philadelphia, the greater Philadelphia area for years, do you think that helps portraits like the one of Antonio? Do you think that actually helps people think about the broader policy issues and implications of the choices and decisions they make in different ways?
Oh, yeah, absolutely. I mean, at the Camden Coalition is a very data-oriented place, right? And I came to the Camden Coalition from the Children's Hospital of Philadelphia Research Institute, in part because in such a small community-based organization, they did data, the quantitative data, really well. But they got the qualitative side of things. They got that unless you really, really understood what was happening for people on the ground, you weren't going to make the practice and policy changes that needed to happen. And so we have a relatively small care management program, but so many of our policy and program decisions come out of the stories of our patients, and from what we hear from our care team, right? So Mr. Moore's go-to, Brian Thompson, one of our frontline workers, I'm going to run something by him because, he just has the reality check of our clients, and that's really important.
2020 has been a huge year for the Camden Coalition. You guys, for several years leading up to 2020, were conducting a randomized controlled trial, looking at effectively whether or not this hot spotters concept that was first created when Jeff Brenner was running the organization was an effective way to transform how you provide care to some of the sickest, most marginalized people in the country. And ultimately, that the RCT results were going to be coming out at the beginning of 2020. And in the middle of the year, me and my staff reached out to you and your staff to say, hey, this report's going to come out sometime soon. Would you be willing to talk to us? Would you be willing to let us do lots of interviews, talking to you and many people on your staff, and then also people who your clients and your patients? Would you be willing to do that? Can you walk the audience through what sort of decision making you guys had to go through to decide whether or not.
Just lost you for a second. I don't know if I lost you or you lost me.
Yeah, we lost Dan for a second.
We lost Dan for a second.
Yeah.
Well, I will answer the question. I know what question he's asking me.
Okay.
And then he'll come back on. So what Dan was asking me is what decision making we went through in sort of figuring out to let trade-offs in to our organization. So at that point, I should say that when I want to be clear, when I got to the Camden Coalition a couple of years before that, maybe a year and a half before that, I did not know the results of the randomized control trial, which was looking at our care management intervention. And I thought, having spent a lot of time in research, that either way, whether we showed an effect or no effect, that it was a contribution to the field, because health services research on this very, very vulnerable population is not typically done. There had been care management studies done, but they were done on a much less vulnerable population. I can't remember the times, if it was 5 times as vulnerable, but we were dealing with people who were extremely vulnerable. And so anyway, by the time Dan came and asked, a very small group of us at the coalition knew that the trial showed no effect between the intervention group and the control group on care management. And that was no effect, a 90-day intervention, and then 180 days out looking at readmission to the hospital. We did show a statistically significant effect in terms of difference to SNAP benefits, to food benefits. But it was really MIT's study, so we were operating under a very strict embargo. And so giving Dan sort of insight, or giving him the results, but then also having him work with staff who did not know the results of the study, because it was really a very small group of us that knew, was a big, was just it was a big decision. And, at that point, I understood that the story was really, really complex. Not just the story of the study, but the story of the lives of the people that we were trying to help. And our team from the beginning didn't want this to be a story about, us questioning the value of a randomized controlled trial or us questioning the results. We wanted to let those be out there and instead use this as an opportunity to really talk about the complexity of the population, and that for this population, care management alone was not going to remedy a lifetime of suffering, for many people of racism. And so the bet was, could Dan tell that story? Could he tell the story of the complexity, and also leave people with something to think about as far as like, what kind of system were we building? And so we took that bet, and we didn't know how the story was going to turn out. We did a lot of taping. We gave Dan access to, we don't give access to clients who haven't graduated our program. So if you've graduated, we just try not to complicate people's lives if they're early in working with us, but gave him access to people in our program. Mr. Matthews, you spent some time with him, Larry Matthews, And we were very, very pleased with how the story came out. It told a story. It was a story about, you know, just how difficult the work is, and that there's more work. There's so much more to be done. So let me stop there.
Thanks for picking that up. Sorry for the technical difficulties, everybody. Thanks
No problem.
so much, Kathleen.
Yeah.
What were the stakes for your organization? Like set aside sort of the news coverage for a second. I mean, ultimately, as an organization, you were looking at a randomized controlled trial, a very rigorous one done by one of, you know, the nation's leading health economists, coming back and saying that a lot of this idea isn't working the way that people had hoped, the way early data suggested it was working. What were the stakes for your organization?
You know, I think in some ways the stakes felt high because we were, because people felt like the stakes were high, you know, outside, because, you know, I say people like a dramatic story and they like sort of, you know, flashy winners and then, you know, stories of losers and so the stakes felt very high. They felt very high around our finances. They felt high around fundraising. They felt high to me, to be honest with you, about people saying, well, nothing can work for this population, right? That somehow, if the Camden Coalition, you know, which, you know, sort of tries to smother people with, you know, sort of helping them. I don't mean that, you know, but just we really, really get out in the community and try not to take no for an answer from people who've been burned out by people who come in and out of their lives. You know, if they can't help them, then nobody can, right? And so, so the stakes were really, really high.
And to address those high stakes, you wrote an article, an opinion piece that ran in Health Affairs. And the other part of your sort of strategy, although as you said, you didn't know what the Tradeoffs episode would be, but that our 20+ minute episode and your op-ed were part of how you were trying to like take control of the narrative. Can you talk about that and give, you know, a lot of people on this call, I believe, fund direct service providers. They want to see people like you thrive. They believe in your mission. They believe in the execution of an organization like yours, a national leading organization. What role did communications effectively and media coverage play in you trying to continue to do the work that you're trying to do?
Yeah, well, I think that, I mean, our strategy, and it's certainly what we tried to convey in our conversations with you and then in my op-ed, was to not apologize for the findings, not apologize or equivocate for having been part of the study, but use it as a vehicle to say, we have a lot more work to do. You know, that it would have been amazing, as I said to you, to have found that a 90 to 120 day intervention with an incredibly vulnerable population was sufficient. But it wasn't. And so it just means that we have more work to do. And we've got, you know, Mr. Moore, who you talked to, he's doing better than he's done in such a long time. Mr. Matthews, you know, who you talked to during the RCT. I mean, these are people that we would otherwise see on the street, you know, who are, you know, Mr. Matthews, just to give you a little update, finally got his birth certificate, which was such a big thing for him, and passed his written driver's test. So he's, you know, these are people that want to find a place. And so, you know, when people ask me about, you know, all sorts of things going on related to homelessness, and I just say, you know, we have to figure out, you know, what is the place that some of these folks want and how to help them get there. So that was really our strategy, is just to use the results to say these, you know, have not in any way got in the way of our resolve to work harder to figure out what helps, because we know that for many, many, many people, it does help. And so figuring out for those people it doesn't help, what might help, how we can adapt our intervention to help them better, you know, that's really important to us.
And so ultimately, what impact did the op-ed have? What impact did the media coverage have?
Yeah. Well, you know, I think, as I said, I think there were two things that we heard right away. You know, that people in health policy knew you and knew your podcast and knew that we had agreed to really open ourselves up. And then that I wrote an op-ed basically simultaneously with the publication. I think it conveyed to people that we were not ashamed, and that we wanted to dig in, and that we were willing to have really tough conversations. You know, for example, one of the person that you featured in your story was a guy who in our intervention shows up as a fail, right? Because we lost him to follow-up within 2 weeks. And so in our data, he doesn't look good, right? And yet a couple of years later, in work we do where we identify people who we think would benefit from our intervention, he showed up again and we reached out to him again, and he was ready then. And he is now living a sober life and trying to do, to feel better than he's felt in a really long time. And so we know that within a lot of those fails, there are people where it just wasn't the right time. And so, you know, we want to be able to tell that story better. We certainly think, you know, we agreed to the metric looking at us in terms of reduction of admissions into the hospital, but we know that there are other things that we have to maybe point to and track and look to show that people are doing better. So
having this conversation with you, I think, and bringing it back, and we're about to kick it to Ben to open it up to the audience for Q&A here. But before we do that, I guess I want to try to end where we started, which is talking about you trying to do really important work on the ground related to the pandemic, and working with the community partners that you and your organization have painstakingly been building and cultivating for over a decade. The world you trade in and the world your partners trade in is a world of, and I'm just reading from my notes that I just wrote down here. You trade in a world of imperfect fixes, real people, and you're trying to have tough conversations. And that's really hard to do. What advice do you have for the folks on this call who, whether they're investing specifically in you, in the Camden Coalition, or in other organizations, probably have similar goals of dealing with imperfect fixes, talking about real people, and trying to have tough conversations. What advice do you have for our audience here, Kathleen?
Well, first of all, make sure your people are okay. There has to be a parallel process between your own staff and the staff that they are trying, and the people that they are trying to help. And so I think we have a lot of work to do in human services around benefits and salaries. And, Robert Wood Johnson Foundation just said that they're willing to now go from maybe 12% overhead to 20% overhead. But so many of the human services organizations are just not, we're squeezed as tightly as some of our clients. And so I would say, you have to feel like I have an embarrassment of riches when it comes to my staff. I may not have an embarrassment of riches when it comes to my budget, but, and convey that and feel that way so that they can bring that out to their clients. So it has to start. And so I would say that I'm hearing a little bit more from funders. I heard it on a call the other day to really provide operating support. There's so many things that can be done, but we have to strengthen some of our organizations that are caring for the populations we're serving. I said when I was at a big institution, we would spend thousands of dollars on coaching at the executive level. I don't have $1 to spend on coaching for my team, some of whom are people who themselves came from underserved, communities. And I want to build them up so they can be the leaders, but we need support to do that. So I guess that would be the first thing I'd say.
Very good. Well, I think seeing a couple of questions pop up in the queue here, I think there are going to be some. Ben, I'm going to pass it over to you. And just real quick, want to say, Kathleen, thank you very much for putting yourself in the spotlight again and having a tough conversation about real things.
Yeah, well, I thank you for telling the stories in a way that captures the complexity.
Thanks.
Yeah.
And my thanks to both of you. So we've got a lot of questions that have come in here, and I've got my own questions, but in lieu of time, let me go ahead and throw up the ones that have been asked so far. So our first question is from Stu, and Stu asked, when the dust settles, are there lessons advice from the public health perspective that will better inform larger discussions regarding emergency management in whatever form that might take or might come? Kathleen, I think that's to you. Any thoughts or comments on that question?
I do think that a lot of communities are now thinking about more about the disconnection between their county health departments and the health systems. And hopefully there'll be some conversations that come out of this around, again, decision-making and who's in charge. I alluded to the board retreat we had, and over again from every partner was the sense of nobody felt like anybody was the quarterback. So the community members might have thought the hospital was the quarterback, but the hospital said, no, we weren't the quarterback. So hopefully some conversations about quarterbacking that really bring in the public health department in a different way, I think.
Thank you for that. Another question that came in that I from our friend Joe asks, if the podcast makes Antonio real for policymakers, how can philanthropy working with nonprofits make the work real for all citizens, as the disconnect is just not among policymakers? I think that's a really important question. Dan, do you want to try and take that one on?
Yeah, can you throw it at me one more time, Ben, so I can.
Yeah, so it's really an articulation of what I think you both expressed here, which is that this podcast made a story extremely real, And it did so for policymakers who could take that story and then make whatever deliberations they might want to make. And I think Joe's point is that for foundations, oftentimes we have stories of success that don't get told. That is frustrating for a lot of us on the front lines that see those stories, but aren't able to necessarily have a format or modality like a Tradeoffs to articulate that story to ultimately bring about some type of change. So maybe it's just the application from healthcare to philanthropy and what that might look like for foundations that are looking to tell those stories.
So I think that philanthropies, and I want to set aside, like I know part of this is about trade-offs and supposed to be about trade-offs, but I'm a little uncomfortable with that, frankly. Like at the end of the day, what I've learned as a journalist in 20 years is that like everything else, it's always about relationships. And I think philanthropy, I would encourage the philanthropists on this call and others to begin to try to develop real meaningful relationships with certain news organizations or individual reporters. And by that, I don't mean necessarily funding the work per se, but getting to know and understand what reporters and media organizations really care about and what is a priority for them, and begin to say, hey, we do work in this area that is of interest to you, and we as the philanthropy will work hard to make sure you're getting up-to-date information, sometimes exclusive information, because we really want this to be covered. And we can also provide you with some expertise so you can have some context. It's not just the project, but it's the larger context around that. And I know from having worked in newsrooms for 2 decades, people really stretched thin and have a hard time keeping up. And so if a philanthropist can really become a partner to a media organization in that way around stuff that the media organization is interested in, then I think you could start to really see more coverage of that particular area in a way that can be disseminated more broadly than if the philanthropy itself decided, we're going to set up our own podcast and just start to disseminate our own information. I think working with a third party lends some real credibility that the philanthropy ultimately wants, if what the philanthropy wants is, sound foundational change.
It's really helpful. We have some more questions that have come in, but I want to ask my own here for a second, just because of what you said, Dan. As foundations, we oftentimes look at how do we measure the impact of our investment? What does that dollar get us? And some of us count, it's the number of people, lives touched. Some of it might be health outcomes. If you think about investing in something like a podcast and, the high-end journalism that you and your team bring, how do you all measure your own impact and your own successes? I'm just not as familiar with this as I might be the work that Kathleen's doing. So maybe you can educate us and tell us a little bit about how you measure that impact.
Sure. No, thanks for the question. We measure impact in a couple of ways. One is through our audience numbers, and specifically, that I think lots of podcasts, lots of media organizations try to understand how big their audience is. And I'm psyched to say that even though we just launched in October of 2010, based on our listen numbers, we are in the top 10% of all podcasts. So that's one way we're trying to do it. And another way we try to do it is hearing directly from our listeners. We did an audience survey in the spring, and we know most of our audience is made up of health policy folks, insiders and influencers. And 50% of the people who responded to the survey told us that as a result of listening to some of our episodes, they now think about an issue in a new way. And that's pretty exciting to us. And it was honestly part of the hypothesis, because what I learned at Marketplace was that, and this is going to be a surprise to nobody on this call, but that because healthcare is so siloed, just because you know drugs doesn't mean you necessarily know much about Medicaid. Just because you know a lot about Medicaid doesn't mean you necessarily know a lot about hospitals. And so if you can have a health policy podcast that's really trying to cover the waterfront in a lot of different ways, you have an opportunity to share some information with people who they think they should know it, but they really don't. And I'll just end on this. We had one very prominent health economist in the country. She sent me an email after we did one story that was an explainer with Larry Levitt from the Kaiser Family Foundation, who was explaining some complicated thing about a Supreme Court ruling in relationship to the ACA, to Obamacare. And this economist said, I've been hearing about this issue for 5 years, and now I finally understand it for the first time. And like that has happened to all of us, right? Because it is a really complicated place. So those are a couple ways that we try to measure impact, anecdotes and our numbers, our audience numbers.
That's great. And I won't ask you about your colleagues and how they measure their impact, but that does seem quite sophisticated. And so I appreciate that, Dan. Kathleen, another question for you, and then we're going to start to wrap up here with our time. When you were talking earlier, there was this beautiful sentiment that you expressed, and one of our colleagues on here asked you this question around not apologizing and the importance of not apologizing. And so the question is, they would love to hear you expand on that, because foundations, and I think this is coming from a very sincere place, we often need to hear that the work is powerful, but not always perfect. So, I mean, maybe you could just say a couple more paragraphs about the not apologizing piece. And don't let the perfect be the enemy of the good. I mean, ways that we can continue to do great stuff, but not necessarily again, as you said, not apologize all the time when it's not perfect. Please.
Yeah. Well, I worked at a foundation at one point a while ago, and felt there like, if we don't innovate, who will? It's interesting. I was having a conversation the other day with a potential funder, and they told me these two things they wanted to do. And they wanted to try to, really be sort of race forward, as at least some people are using that phrase. But they also wanted to think about one of our evidence-based interventions, and other than the RCT, we have other interventions we've done where we've had. And I said to them, I love hear all the stuff you're talking about, but they are in tension with each other, because a lot of the innovation that we're doing related to race, and particularly health services, doesn't have an evidence base yet. Right? So we can roll out and scale, something we've done in Camden called the 7-Day Pledge, which is a health services kind of intervention. But it won't be innovative at this point, because we were, a lot of hospitals have actually done that. They've now, they've incorporated the 7-day HEDIS measure. But if you want to innovate, we can do that, right? But we're going to have a lot of misses then. But let's do that then. Like, let's do that, and let's do it and be as thoughtful as we can be, and build in CQI and all the other things you want to build in. But it can't be grounded on an evidence base that is there already, because it's not.
Beautifully said. Thank you for that.
Yeah.
I'm going to ask one more question, Dan, to you, and then I'm going to wrap up here, and we can all get back to our day. Dan, when I think about the plethora of topics that are out there, and we three are all policy wonks, we live in the deep end of that pool, there's so many things to choose from. And as you said so eloquently earlier, just because drug pricing doesn't mean Medicaid. And how do you, as kind of the guy in front of the mic, pick and choose what you want to focus on? And I say this as a listener to your podcast, because I think that the way you've been able to structure the podcasts, it feels like they're all connected, though they're different. And sometimes you do have them connected. You refer back. It's beautiful. But how do you pick and choose what you cover? And then where, as a reporter, where do your own personal biases come in there? And choosing one particular pet project over another? Maybe you could speak to that for a second.
Sure. Thanks for the question. We start with our goal, And the goal is to produce something that feels relevant and something that's meaningful. And when I say meaningful, we're talking about something that really promotes, and it goes back a little bit to that conversation, that point I made with Kathleen about having hard conversations. Like the mission statement of Tradeoffs is to help people on Main Street, Wall Street, and Capitol Hill get smarter about health policy. And like, we want to do episodes that are going to challenge people in how they think. And we're going to do that with data, and we're going to do that with human storytelling at the intersection of how policy impacts money and people. And so that's really the kind of like first pass of any filter we do, right? Like, we really want to make sure that these stories have data and research. We want to make sure that these stories have human characters, and we want to make sure that there's a timeliness, a relevance to it. So right now, so in the last 5-6 months, we've been focused a lot on COVID. If the Supreme Court situation goes the way it potentially could, and the Affordable Care Act is overturned, and then there's a replacement to the ACA, if there is a replacement to the ACA, then a lot of our coverage in season 2 would be looking at that. But I think, you know, you ask about that's sort of the overview of this is hard. There's nothing clear about this, but having been a journalist for 20 years, certainly what's newsy to me sort of informs this. So that's one of the biases. And the other bias is that we're really always interested in doing stories that look at spending and efforts to control spending, better use spending, and also how you can, in fact, improve the lives of people. And the final bias is we're really interested, and I have been my entire career, long before I was a healthcare reporter, interested in stories about marginalized people. And I think healthcare is one of the areas where there's an interest in equity in healthcare in a way, as a journalist at least, that you don't see in other beats. And so it's really awesome to be able to focus on marginalized people.
Thank you, Dan. That's a beautiful response, and I just want to commend you both, because in your own worlds, you're such amazing leaders, and I think that the last hour has been nothing but a good opportunity to not only get to know you a little bit better, but to know of how things connect and how we can align some of the dots out there to make impact. So, Kathleen, thank you. Dan, thank you.
Absolutely.
Yeah, just to close out here really quickly. Our goal for today was just to have a conversation and to let some of our friends know on the power of certain modalities like podcasting. When you get talented folks like Dan connected with unbelievably talented on-the-ground leaders like Kathleen, the story that's told with data is a very different story than what we oftentimes read about or even see sometimes in our reports. And so we just wanted to offer that up as an opportunity here for us to learn, because sometimes it is hard for us to tell those stories. So Dan and team have developed a unique method that I think, in a model that helps us better disseminate findings with a human face and voice. So now it's up to us. How can we continue to support talented folks like Tradeoffs to help share our work? Part of the reason we wanted to do this event is to offer up an opportunity to not only share a little bit about Tradeoffs, but also to connect those of you who might be interested in supporting something like Tradeoffs. So I know Dan would be more than happy to talk to each of you at your organizations. But it is really our intent to make sure that good people telling great stories like Kathleen, like Dan, continue to have the support necessary to be successful. And that's part of the reason why we wanted to do this today. So thank you all for your time and your attention. If you're interested in learning more about Tradeoffs, you can go to their website at tradeoffs.org, or I'm sure you can just shoot Dan an email and let him respond in his own way. But my thanks to you all, and thanks again, Kathleen and Dan, for your time today.
Thanks so much. Appreciate it.
Be well, everyone.
Thank you very much.
Bye, everybody. Thank you.
Thank you.